Good afternoon, everyone. iTech India welcomes all the participants for today's RDLS session. Today's topic is HIV and OI gastrointestinal system, and the speaker is Dr. Sonali Salvi. Dr. Sonali ma'am is the associate professor and unit head with the Department of Medicine at BJ Medical College, Pune. She has received training in PG DGM, clinical management of HIV, comprehensive hemophilia management, and evidence-based diabetes management. Additionally, she is a member of SASIP at BJMC, Pune. We welcome you, ma'am, for today's session and request you to start the session.
Good afternoon to all of you, and I would really thank iTech and MSACS for organizing today's session. And it's a very important topic from day-to-day practice. So let's begin with the session today. So let's discuss the session contents first. We'll study in short about the background, the oral pathological lesions, various lesions like candidiasis, angular stomatitis, and then causes of diarrhea, the definition, classifications, etc., and bacterial infections, management of diarrhea in CLHIV, cryptosporidiosis, cystoisosporiasis, other causes of diarrhea in PLHIV, and anal lesions. Next. So gastrointestinal disorders are among the most frequent complaints in patients with HIV infection. As you must have seen in your clinical practice, most of the patients usually have some sort of gastrointestinal symptom, either at the onset of the antiretroviral therapy or when they are on antiretroviral therapy, or in patients who are ART naive. And multiple GI infections are also common at the same time. So at the same time, you will have one or two infections occurring concurrently. Next, please. Common gastrointestinal manifestations of HIV disease are. So this is a very important slide, and it usually encompasses the entire spectrum of the disorders of gastrointestinal tract. So diarrhea, dysphagia, odynophagia, nausea, vomiting, weight loss, abdominal pain, anorectal disease, jaundice, hepatomegaly, gastrointestinal bleeding. So these are the common manifestations, and these are the pointers. Once a patient comes with any of these complaints, you are supposed to evaluate the patient and not just give symptomatic therapy. So that's a very important punchline of this, is that you have to identify the complaints at the earliest and try to correlate it with the clinical status of the patient, his CD4 count, his viral load, and give him a comprehensive treatment. Just you are not supposed to be just giving him over the counter, or you're not just here to just give him prescription for some diarrhea or some dysphagia, but you're supposed to clinically assess the patient and give comprehensive management of the same. Next, please. So oral pathological lesions are candidiasis, oral and esophageal. You have angular stomatitis. Angular stomatitis is nothing but you have the angles of the mouth. They get inflamed, and there is sort of fissuring and some sort of oozing also. And what it leads to very difficult and painful mouth opening, and that restricts the food intake in these patients, creating further issues. Then oral ulcers also, by similar mechanism, they will interfere with the patient's eating habits. Kaposi's sarcoma is a rare condition, we'll be discussing with it. And necrotizing gingivitis is a very painful disorder of the gums. Next, please. Now, oral candidiasis or oral thrush, it is caused by yeast called as Candida albicans. In HIV negative, it occurs commonly in infants, the elderly, uncontrolled severe diabetic population, and persons on prolonged antibiotic therapy, high dose corticosteroids, immunosuppressants, cytotoxic drugs, etc. But in PLHIV, it is pointed towards more advanced immunodeficiency with a persisting oral thrush qualifying as stage 3 disease. You all have known that we have staging of the disease in HIV, and in that point, if you have oral candidiasis in a patient, then it is stage 3 disease. So it is not expected to be there. Suppose a patient is doing really well on your antiretroviral therapy, the patient is not expected to have oral thrush. However, this can be a somewhat confusing picture in patients who have HIV infection as well as conditions like bronchial asthma, where patients are on bronchodilator therapies, which constitute oral or either inhaled form of any corticosteroid. In that case, they will have oral candidiasis as a presentation. And in those circumstances, you will have to be really careful in labeling whether this is immunodeficiency or patient is not doing well on ART or patient is doing well. So take a detailed history of the concurrent medications as well. Next, please. So the clinical presentation, you have, I think all of the medical officers have seen and dealt with this condition since many years. It's not a new thing to you. And it is commonly seen as white patches that can be easily removed by scraping with a tongue depressor surrounded by a reddish border. And it involves mostly the oral mucosa, pharynx, inner side of the lips. 4 clinical types of candidiasis are pseudomembranous, that is oral thrush, what we call the commonest one, erythematous or atrophic form, angular cheilitis, and hyperplastic. Now, PLHIV often complain of having no taste. Now, this taste disturbance is because of the taste buds are being occupied by these candida and yeast called as candida. So that is the reason why they do not perceive taste as, and some patients you must have observed them complaining as when they eat say spicy items, then they complain of excessive burning or intolerance to spicy food. That is a very early presentation of candidiasis. And swallowing is frequently painful, but there is a slight difference. It is just in the back of the throat and not lower down behind the sternum. Now, this point is very important because this point differentiates between oral candidiasis and esophageal candidiasis. And all of us know that esophageal candidiasis is stage 4 disease. So, when you are asking history of a patient with regards to swallowing difficulty, you should be careful enough to ask whether it is just in the mouth or in the back of the throat or it is also behind the sternum. Next, please. Oral candidiasis, how do you diagnose? Usually it is a clinical diagnosis. It's a very easy clinical diagnosis. Now, it has a characteristic appearance of the lesion. In contrast to oral hairy leukoplakia, the white plaques of oral pharyngeal candidiasis can be scraped off the mucosa. Now, when we talk about the oral hairy leukoplakia, it is also a very common lesion which is seen in the Indian population, especially with the tobacco use. And this slide very beautifully tells you how to differentiate it. It can easily be scraped off in case of candidiasis, whereas in case of oral hairy leukoplakia, it may not be easily scraped off. Now, lab confirmation scrapings can be examined microscopically for characteristic yeast or hyphal forms using a potassium hydroxide preparation. Cultures of clinical exudative material yield the species of Candida. Now, treatment is nystatin oral suspension 1 ml swished around the mouth for a few minutes and then swallowed. That means it has to be retained in the mouth. So you have to tell the patient specifically that once you have this oral suspension in the mouth, it has to be turned around inside the oral mucosa using your tongue and retained for a few minutes, and then it has to be swallowed. This entire process has to be repeated 4 times a day for 5 days, and this is the initial treatment. After this, you can have a topical application of 1% clotrimazole mouth paint if the lesions are very focal or pinpoint, and if the thrush persists or recurs, oral fluconazole 100 to 150 milligram once a day, and in children up to 6 milligram per kilogram per day for 1 week is very effective. And we have seen that some patients do require a treatment even more than 1 week. So in that case, you may extend it for a period of 1 week additionally. But usually 1 week is sufficient enough to clear the lesions. Next, please. Now, esophageal candidiasis is a WHO clinical stage and stage 4 condition, usually diagnosed clinically on the basis of presence of oral candidiasis and associated subjective symptoms of difficulty in swallowing and painful swallowing. So that's very important. So not only dysphagia, that is difficulty in swallowing, but also painful swallowing. That means patient has severe pain, and that is the thing that limits the patient's eating habits, or it will limit the food intake to such an extent that they'll have significant weight loss. Anyone with complaints of dysphagia or odynophagia and having oral candidiasis will should also be treated presumptively for esophageal candidiasis. So that's the dictum. If you have such a type of pain, then you also have to treat the patient for esophageal candidiasis. Next, please. So as oral candidiasis can cause pain in the throat on swallowing, the important question to ask is if the PLHIV has pain behind the sternum on swallowing. So in this is a very typical attribute, and you have to be very cautious in taking this history. And this occurs more commonly with lower CD4 count, especially if oral thrush is present. Esophageal thrush qualifies a patient to be in WHO stage 4, and other stage 4 diseases also may coexist. So we'll be discussing in short about other conditions as well. Now, symptoms like loss of weight, lethargy, or any danger signs should not be attributed to esophageal candida alone. So if you have, say, this is a very common scenario when we usually consider or we give presumptive treatment for esophageal candidiasis, and the patient doesn't seem to respond to it. And sometimes we have seen the oral lesions healing well with the antifungal therapy, but patient still has severe odynophagia. These are the cases where, in addition to candida, you must suspect the other opportunistic infections like CMV or herpes. So, clinical presentation. Next slide, please. So clinical presentation in children, unlike adults, they often experience nausea and vomiting. Children with esophageal candidiasis may present with dehydration and weight loss. And classical symptoms and signs of esophageal candidiasis may be absent in children with esophageal candidiasis, particularly those receiving ART. So in patients who are regularly taking antiretroviral therapy, you may not have classical findings. And another thing which is very difficult in case of children is, suppose an OGD-scopy is to be performed, there are technical difficulties. So they have to be anesthetized, and then all those procedures need to be carried out. So a little bit of difficulty in confirming the diagnosis, especially in cases of children living with HIV. Next, please. So diagnosis is often empiric, and it is based on symptoms and response to therapy, or visualization of lesion plus fungal smear in cases where you can do OGD-scopy or upper GI-scopy. This can be easily confirmed. Now, definitive diagnosis, however, requires direct endoscopic visualization of lesions with histopathological demonstration of candida in its yeast form, and confirmation is done by fungal culture. Now, what are other possible causes of painful and difficult swallowing? These are gastroesophageal reflux disease and esophageal ulcer, which can be either idiopathic or related to HSV, ulceration of the esophagus with cytomegalovirus, and this has to be highly considered if the patient's CD4 count is less than 50 cells per cubic millimeter. Kaposis sarcoma and tuberculous ulcers, these are rare. Next, please. Now, very important treatment of this condition. Fluconazole 200 milligram orally daily for 14 to 21 days, and check the response to treatment after 7 days. So if there's a good response, continue the fluconazole for 10 days to 2 weeks. Now, this is a very, very subjective thing. We have seen in clinical practice that patients who come at 7 days follow-up, they still have persistent lesions. So in these patients, you can extend the therapy for 14 to 21 days. And that is the importance of close follow-up. So whenever you diagnose any opportunistic infection, patient should be asked to follow up every weekly so that you can assess the conditions. Now, there is one more way of doing it. You can have clinical pictures of the photograph or photographs of the patient. So patient can take self photograph and bring those for documentation that these were the lesions and these are the lesions now. Um, However, if the patient's symptoms are worsening, then it is worth considering other diagnosis as we have already discussed. If fluconazole is not effective after 1 week, consider other causes as listed earlier. If not responding, treat for HSV with acyclovir 400 milligram 3 times a day for 10 days. Majority of those with CMV related esophagitis will develop CMV retinopathy as well. So even though vision may deteriorate late in the disease, still ask about it and examine the fundi, especially if CD4 count is less than 100 cells per millimeter cube. And the treatment of choice is valganciclovir and alternative is ganciclovir. And if ensure that effective ART is being taken after screening for TB. Now, why is this important? Effective ART being taken, it is important because if patients compliance is reduced because of painful lesions, then it will invite further opportunistic infections because the patient's CD4 count is going to decline further and the viral load is going to increase. So this is very important whether the patient is able to swallow the antiretroviral medications or not. That is to be asked to each and every patient. And importantly, if the CD4 is declining, then you have to get the fundus examined for CMV related retinopathy because initially if you diagnose it before visual disturbances occur, you can treat it successfully and serious cause of visual impairment can be prevented. Now in children, fluconazole loading dose should be 6 milligram per kilogram dose once on day 1 and maintenance is 3 to 6 milligram per kilogram dose once a day for 4 to 21 days. Now next slide please. Angular stomatitis. So angular stomatitis or angular chelosis, or it is also known as angular cheilitis. Angular stomatitis presents as inflamed, painful cracks at the corners of mouth. It is usually caused by candida. It can also be produced by iron deficiency, occasionally bacteria, and usually responds well to 10 days of antifungal cream such as clotrimazole and even nystatin drops rubbed into the cracks. So you should treat the concurrent iron deficiency and you should also give multivitamins because most of the B complex deficiencies also can produce this type of presentation. Next, please. Oral ulcers, aphthous ulcers or canker sores. These are one or more ulcers on the mucosa of mouth, inner lips, and sometimes tongue. Cause is unknown, presumed to be viral, often persistent and painful, especially in PLHIV with lower CD4 counts. Treatment is effective with antiretroviral therapy. If already on ART, ensure that the patient is virally suppressed. This can also occur after exposure to various other medications, antibiotics. So history has to be very carefully taken and patient should be asked to follow. So because if single ulcer and which is persistent, non-healing, you may have to inquire regarding other etiological causes as well and evaluate accordingly. Now, herpes simplex virus, it may present as shallow ulcers or blisters that are painful, extensive or recurrent, often on lips as well. And these lesions, as you see in the picture on the upper lip, it is severely affected. And especially when they involve the angles of the mouth, they will produce similar condition like angular chelosis. And there will be difficulty in opening of the mouth. And patient should have a bland diet, non-spicy, and try to avoid acidic foods. Paracetamol with tramadol can be used for extreme pain relief. Acyclovir 400 milligram 3 times a day for 5 to 10 days is effective. Now, neuralgia, post-herpetic neuralgia, is also very common, and that needs special attention, because this dull aching pain of the ulcerative eruption versus the sharp shooting pain of the neuralgia, that has to be differentiated. If there is additionally trigeminal neuralgia or any segmental neuralgia, then these patients must receive some additional form of therapy. You may have to give tricyclic antidepressants or pregabalin, similar kind of treatment for neuralgia. Now, topical acyclovir is ineffective. It's not very effective. In children, you have to use 15 milligram per kilogram dose 5 times a day for 7 to 10 days. A very important thing when you're using acyclovir in patients is to ask the patients to have adequate water intake, because it can precipitate nephropathy. So, if the patients has a condition predisposing to any sort of renal issues, then this should be used with caution. So, you must ask the patient to ensure adequate water intake so that the kidneys are flushed off, and you do not land up with a nephropathy. Next, please. So, another form of oral ulceration is syphilis. The reason why I asked you to have a close observation on the single ulcer is because the ulcer of primary syphilis and chancroid also look very similar. And the key difference is that in syphilis, it is almost always painless, whereas in aphthous ulcer and chancroid, it is very, very painful and may have a very erythematous and edematous margin. VDRL must be done to confirm the diagnosis, and treatment is benzathine penicillin 2.4 million units intramuscularly weekly for 3 weeks. So it should be treated just like any other form of syphilis, and you have to ensure that patient is treated completely at this stage itself. Next, please. Kaposi's sarcoma is a very rare lesion in Indian scenario. It's usually seen in African countries, and the clinical presentation, it usually presents with purplish, fleshy swelling on the roof of the mouth or gums, which usually bleeds, and it may the color of the lesion may vary. It may be plain flesh-like colored, or it will be violetish colored. If present in the palate or oral cavity, it may indicate pulmonary or GI tract involvement. And investigations with chest X-ray, especially if any respiratory symptoms are present, and check hemoglobin, as it often results in anemia due to occult GI bleeding, because similar mucosal lesions are likely to be present in any part of the gastrointestinal system, especially the upper GIT, and it keeps on leaking blood, and it has to be confirmed using a upper GI scopy. So a diagnosis is usually made on history and appearance. However, confirmation may require histopathological examination of the lesion. Now, treatment, it is WHO clinical stage 4 disease, and the first and primary treatment is effective antiretroviral therapy. If the patient is ART naive, start ART immediately. If the patient is already on ART for more than 6 months, then evaluate for treatment failure. Urgent viral load is recommended, and if failing first line ART, switch to the second or third line treatment following NACO's guidelines. In addition, PLHIV is to be referred urgently for chemotherapy. So chemotherapy is usually required because it is a malignancy. So you have to take a consultation of oncologist, medical oncologist. Next, please. So necrotizing gingivitis, it's a rather uncommon condition, but often missed. It is an inflammation of the gingiva, may lead to tooth loss, severe pain, or foul smelling breath. So this is a clinical presentation, and periodontal disease is a very common disease in the PLHI. So in general, if the oral hygiene is poor, and the patient's immuno competency is declining, then you are likely to present with this. So management is oral hygiene, antiseptic mouthwashes, antibiotics, metronidazole 400 milligram orally 3 times a day for 7 days. That is very, very effective in treatment of this condition. And pain management is using paracetamol or paracetamol with any other formulation. This is again a WHO stage 3 condition, and one must ensure that the PL-HIV is on effective antiretroviral therapy. Sometimes in such cases, dental reference is also required. So in cases which are not responding, then these should also take a dental consultation. Next, please. So causes of odynophagia. Let's now discuss all the causes together. So whenever a person comes of severe painful swallowing, then you must think in terms of fungal disease, viral disease like HSV or CMV, idiopathic HIV ulcers, gastroesophageal reflux disease, and drugs like AZT or NSAIDs also can produce such a manifestation. Less common ones are bacteria, the staphylococcal infection, or tuberculosis. Tuberculous ulcers of the esophagus are very, very rare. Fungus, histoplasmosis. Histoplasmosis again, not it's not a rare condition. It has been seen recently in some patients. We have seen patients who are immunocompetent also. Viruses like Epstein-Barr viruses, parasites like Cryptosporidium. So these are the cases which can present with odynophagia, and all the cases which are refractory to treatment must be referred to gastroenterologist. Next, please. So now we'll discuss about diarrhea and other intestinal parasites. In diarrheal disease, it is very important to define the diseases. So first, the classification of diarrhea. It is inflammatory diarrhea when pathogens invade the wall of the large bowel, causing an immune response and mucosal bleeding. And um, so we define diarrhea as 3 or more loose or liquid stools per day, or having more stools than is normal for that person. If a person is having 3 stools per day, scenario can be considered as normal. So if the stool frequency exceeds this frequency, it can also be considered as diarrhea. In otherwise, we have to consider 3 or more loose or liquid stools. So there are 2 important aspects: increase in frequency and alteration in the consistency of the stool. So you have to ask both, how many times you have to go to the washroom in a day, and whether the consistency of the stool is altered. So both should constitute as diarrhea. And there may be associated symptoms, particularly nausea, vomiting, fever, and abdominal pain. Now, diarrhea in children again can be somewhat difficult, especially in an infant. In infant, an increase in stool frequency to twice the usual number per day is, now suppose the infant is having 5 to 6 loose motions in a day, then about say 10, more than 10 to 12 loose motions should constitute diarrhea. Whereas in older children, it is 3 or more loose or watery stools per day, just like an adult. The definition is just like in an adult. Dysentery is associated visible blood in stool. It is called as dysentery. Now, persistent diarrhea and chronic diarrhea are 2 terms which one must understand. Persistent diarrhea, in 5 to 15% of cases, acute diarrhea may persist beyond 2 weeks, which is then called as persistent diarrhea. Uh, Now, this persistent diarrhea and chronic diarrhea, they have slight differences. Now, persistent, when you call it as persistent, it should have an acute onset. Whereas chronic diarrhea, it is a diarrhea of more than 2 weeks with an insidious onset. So it is more like a subtle kind of a presentation. And this term chronic diarrhea is not synonymous with persistent diarrhea. As I've already discussed, the difference lies in the onset of presentation. Now, classically, chronic diarrhea is described as more than 3 months, but in more than 2 weeks duration in children, it is classified as chronic diarrhea. Next, please. Now, what are the consequences of diarrhea in children? In children as well as in adults, sometimes it leads to dehydration and malnutrition. Now, this is a vicious circle. Vicious circle in the sense malnutrition will further reduce the patient's nutritional status and reduce the immune functions of the patients and make them further susceptible to more infection. And that this vicious circle has to be broken at some stage and in order to bring out effective cure. Dehydration is one thing which needs to be treated promptly, because then it will lead to volume depletion, hypovolemic shock, and even can be life threatening. Next, please. Now, there's also another classification of diarrhea: inflammatory diarrhea and non-inflammatory diarrhea. Inflammatory diarrhea is said to occur when patients or when pathogens invade the wall of the large bowel, causing an immune response and mucosal bleeding. Whereas non-inflammatory diarrhea is a consequence of pathogens that superficially invade the epithelial layer of the small bowel and cause increased secretion of water and electrolytes into the lumen. So there'll be more fluid loss into the bowel, resulting in dehydration in this form. Next. Now, causes of acute diarrhea. The causes of acute diarrhea are numerous. So, non-inflammatory diarrhea are usually bacterial enteric infections like Shigella, Salmonella, Campylobacter, Escherichia coli, Clostridium difficile, parasites like amoebiasis, viruses like cytomegalovirus disease. Now, we have recently witnessed a Campylobacter jejuni outbreak in Pune and around. You all must be aware of this fact. Then acute non-inflammatory diarrhea, viruses like rotavirus, enterovirus, noroviruses, and parasites like Giardia lamblia. Now, Giardia lamblia is another one infection which is most often misdiagnosed or not undiagnosed, and that results in chronicity also in most of the cases. Next, please. Now, causes of chronic diarrhea are non-inflammatory diarrhea, which is large volume watery stools, coccidian parasites like Cystoisospora, previously called as Isospora belli, and Cryptosporidium, Microspora, and Cyclosporidium. Then Giardia lamblia, Strongyloids stercoralis. Persistent diarrhea in CLHIV, it is usually because of malnutrition. Then pathogenic E. coli, especially enteroaggregative and enteroadherent types. Prolongation of an acute diarrhea may rarely be a manifestation of cow milk protein allergy. Antibiotic associated diarrhea due to bacterial overgrowth and Cryptosporidium infection. Next, please. Now, the complications of diarrhea are first thing is acute dehydration, which can result in acute kidney injury. And you have to be really cautious in patients who are on tenofovir. So patients on tenofovir, if they have acute diarrhea, their volume status must be replenished adequately so that they don't land up with tenofovir-induced nephropathy or acute kidney injury, which then further culminates into chronic kidney disease if untreated. Now, another complication is systemic sepsis that results from bacterial causes. Electrolyte abnormalities, they are a result of mostly acute form. Malnutrition is more of a persistent diarrhea or chronic diarrhea complication, which usually come in very later phases of the disease when they have actually had weight loss. So that's the importance of keeping or recording weight in your clinical practice. Every visit, the weight measurement is mandatory. That helps you to tell how much weight loss has occurred during the last 2 or 4 weeks of diarrhea. And it also helps you to assess the nutritional status of the patient. Next, please. Let's see a brief about the bacterial enteric infections. Next, please. The epidemiology of the enteric infections, the rates of gram-negative bacterial, previous one. Previous slide, please. The rates of gram-negative bacterial enteric infections are at least tenfold higher amongst the HIV-infected adults. And these rates decline when they are treated with HIV. antiretroviral therapy, and the risk of bacterial diarrhea is greatest in individuals with CD4 less than 200. And the bacteria most commonly isolated by culture are Salmonella, Shigella, and Campylobacter. So I hope all of you know the story of Salmonella. So there was a chef or a hotel worker. He Typhoid Mary was his name, and he was responsible for a massive epidemic of Salmonella because he was a chronic carrier of the Salmonella bacterium, and that spread to several of his clients. So food hygiene was highly talked about in that era, and that case still serves as an example. Shigella and Campylobacter jejuni, which presently also is creating havoc in the community. And Clostridium difficile associated infection is common in PLHIV. Low CD4 counts, less than 50 cells per cubic millimeter, is an independent disease risk factor. And the probable source for most enteric infections in HIV infected patients is ingestion of contaminated food or water. So this is very, very important fact that you must counsel in your daily OPD to patients about their food and water. So hygienic food and water, the source of the water should be examined. If it is not possible to understand the source of the water from which the patient is consuming, then they must be advised to boil the water and consume it, because then you're assured at least most of the bacterial infections are prevented. Next, please. Now, clinical manifestations, the gram-negative enteric bacteria, they have self-limiting gastroenteritis as a very common clinical presentation. More severe and prolonged diarrheal diseases are associated with fever, bloody diarrhea, and weight loss, and bacteremia associated with extraintestinal involvement, or with or without concurrent or preceding GI illness. Now, bloody diarrhea is a very, very alarming feature that brings the PLHIV for some acute management. Now, this um, is usually associated with painful bowel movements, and they also have some sort of tenesmus. That means pain in the anal or rectal region, and that usually gives rise to passage of stool followed by pain or intermittent spasms in that area, and this usually brings the patient to the clinician. Next, please. So, firstly, the complete history, including the medication history, has to be taken. Diagnosis should be established through cultures of stool and blood. The blood culture is especially important if you are suspecting Salmonella typhi. Stool culture will give you results in the later part, but blood culture during the febrile episodes, when the patient is having fever, chills, or rigors, then this will be really beneficial. Now, diagnosis of chronic diarrheal disease is complicated and needs careful selection for correct testing and laboratory findings. Endoscopy with biopsy may be required for conditions like cryptosporidiosis, microsporidiosis, CMV, or Mycobacterium avium complex gastroenteritis, or non-infectious causes. If stool cultures fail to yield enteric bacterial pathogens, then with symptoms of proctitis or colitis, diagnostic evaluation for STDs should be considered. Next, please. So, general considerations in the management, these are common to all the diarrheal diseases. Oral or IV rehydration. Antimotility drugs should be avoided if the patient's diarrhea is undiagnosed. So, never ever give antimotility drugs like Lomotil in patients who have undiagnosed diarrhea. That can lead to serious complications. Sometimes even intestinal perforation also has resulted. Now, diagnostic fecal specimens should be obtained prior to initiation of empiric antimicrobial therapy. If stool sample is obtained, antibiotic susceptibility should be performed. Empiric treatment for all infections should be considered, And antibiotic therapy can be withheld sometimes if until a diagnosis is confirmed. So preferred therapy is ciprofloxacin tablet, 500 milligram twice a day. In cases of children, ciprofloxacin is to be avoided because it leads to damage. It leads to damage of the cartilages. So the young growing cartilages are damaged. You should avoid ciprofloxacin in children. Alternative therapy is ceftriaxone 1 gram OD or cifotaxim 1 gram 8 hourly. So these can be used as alternative agents. Next, please. Now, treatment of salmonella infection. If you have got there is a common tendency to perform Vidal. This I would like to mention specifically. Vidal is very non-specific, and especially in first week of the infection, first week of fever, or first week of diarrhea, if Vidal test is positive, then this should not be considered. Vidal test should be considered highly significant only after the 2 weeks or after the mid 2 weeks. If it starts coming positive, then it has to be considered. Otherwise, cultures are the most definitive ones. Ciprofloxacin 500 milligram twice a day is a preferred therapy. Alternative drugs are levofloxacin, moxifloxacin, trimethoprim, methoxazole combination, ceftriaxone, or cifotaxim. These are highly effective against salmonella. And the duration of therapy, however, varies. If CD4 count is more than 200 cells per cubic millimeter, then 7 to 14 days of therapy is adequate. But if CD4 count is less than 200, then, and if the primary illness is severe, 2 to 6 weeks of therapy may be required. And patients with bacteremia, 14 days or even 6 weeks therapy is needed. So, because they have metastatic foci of infection, that means at various levels there is a spread via blood. So, you have to be really cautious and give extensive therapy in these patients. Next, please. Treatment of shigellosis. So, gastroenteritis, 7 to 10 days of treatment are required. For bacteremia, more than 14 days, and recurrent infections, up to 6 weeks of therapy are required. Now, preferred therapy is ciprofloxacin, and alternative therapies are levofloxacin, moxifloxacin, or cotrimoxazole. Azithromycin also has been proven effective, 500 milligram once a day for 5 days. Next, please. Treatment of Campylobacter jejuni infection, gastroenteritis, usually 7 to 10 days of therapy, bacteremia more than 14 days, and recurrent bacteremia 2 to 6 weeks. Now, bacteremia and recurrent bacteremia cases are very difficult to diagnose because Campylobacter jejuni is a very tedious organism. It is a very hardy one and it cannot be grown easily in blood cultures. So it's very difficult, but bacteremia can be suspected on clinical grounds. And preferred therapy is ciprofloxacin 500 milligram orally twice a day, azithromycin 500 milligram once a day. Alternative therapies are levofloxacin or moxifloxacin. Either of these four drugs can be used. Next, please. Treatment of Clostridium difficile infection, vancomycin 125 milligram orally 4 times a day for 10 to 14 days. This is especially when you have prolonged antibiotic therapy for some other cause and if the patient develops diarrheal disease. So vancomycin is highly effective in these cases. Or metronidazole 500 milligram thrice a day for 10 to 14 days. Metronidazole sometimes may be very difficult to tolerate for 14 days. It will lead to very bad metallic taste in the mouth, and nausea and vomiting are also very commonly seen. Next, please. So, management of diarrhea in children living with HIV. Next, please. So, firstly, you must have objectives set to assess these children. Determine the type of diarrhea, whether it is acute watery diarrhea, dysentery, or persistent diarrhea. Then look for dehydration and other complications. That is first and foremost. When you're looking for dehydration, it is mandatory to record blood pressure of these patients. And if it is not possible at your level, take a pediatrician's assistance in classifying the dehydration, because if severe dehydration is present, these children need intensive care unit admission and management of dehydration as a primary goal. Assessment for malnutrition in cases of chronic or persistent diarrhea. Rule out non-diarrheal diseases, especially systemic infections. Assess feeding both pre-illness and during the illness. So the caloric intake of the patient has to be always calculated in order to know whether caloric deficits or protein deficits are present. Next, please. So the points in history taking, so you can note them down. Onset of diarrhea, the duration, number of stools per day. Again, this varies. Infancy, infant means less than 1 year child. The number of stool frequency, and more than 1 year. So the definition of diarrhea itself is variable, as we have already discussed. Then blood in stools, number of episodes of vomiting, presence of fever, cough, or other symptoms, convulsions, recent measles. These are again to be asked, because post measles also patients present with diarrheal disease and severe malnutrition. Type and amount of fluids, including breast milk and food taken during the illness and pre-illness feeding practices. Drugs or other local remedies taken, including opioids or anti-motility drugs like loperamide, that may cause abdominal distension. And immunization history, that is very, very important. In unimmunized children, the severity of diarrhea tends to be on a very higher side. Next. So, assessment of dehydration, look at the child's general condition. It is alert, restless, irritable, lethargic, or unconscious. Then, appearance of eyes, whether normal or sunken. Ability to drink water or ORS solution, if it is an infant, whether breastfeeding or not, has to be really asked in detail. Then feel for the skin turgor, calling pinching. The abdominal skin may flatten immediately, go back slowly, or return very slowly. If it is taking more than 2 seconds, that means the skin turgor is very, very poor, and that indicates very severe dehydration. Next, please. So classification of diarrhea in children living with HIV. As we already discussed, acute diarrhea less than 14 days, persistent diarrhea, acute onset but lasts more than 14 days, chronic diarrhea, insidious onset lasts more than 14 days, and acute dysentery. These are the classical definitions. Try to classify the child accordingly, and then classify whether no dehydration, severe dehydration, more than 2 signs, or severe dehydration with very extreme features. Now, plan A is home-based treatment with WHO-based ORS. And in severe dehydration, that is moderate or severe dehydration, hospital-based management, again with WHO-based ORS. Next, please. Now, these diarrhea, for management of diarrhea, the guidelines are just like the national program, which is again in accordance with the WHO's guidelines in diarrhea management. No dehydration less than 50 ml per kg body weight fluid loss. Some dehydration is 50 to 100 ml per kg fluid loss, and severe dehydration more than 100 ml per kg fluid loss. Now, how to measure this fluid loss? So you have to actually calculate the volume that has been lost, or you can retrospectively ask the patient how many diapers were fully soaked. Now, it's very important that sometimes you may also need to um, uh, carefully inspect the diapers for the wetness. Sometimes very small amount of stool is passed, and that has been the mother usually tells us that the large volume has been lost. So weighing of the diapers is another option to calculate the fluid loss. Next, please. So examine for features of malnutrition, anthropometry for weight and height, examination of wasting, edema, and signs of vitamin deficiency, systemic infection, presence of cough, high-grade fever, fast breathing, chest indrawing, that suggests pneumonia, and high-grade fever with splenomegaly, fungal infections, oral thrush, or perianal satellite lesions. Next, please. So what are the laboratory investigations? Stool microscopy is usually not very informative, but in selected situations, like in cases of outbreaks of cholera, it is very important. And if you identify cholera as a causative agent, then hanging drop preparation usually tells you, and this is a notifiable disease, and immediately the outbreak should be identified and it should be contained. Because what is the source of contamination? As you have seen, it can create a real havoc and it can spread from patient to patient in no time. GRDS is usually food related sources are very common causes of infection. And stool culture, again, in the acute diarrhea may not be very helpful. Tests for stool pH and reducing substances are not indicated. Complete blood count, blood gas estimations, and serum electrolytes, renal functions, these can be performed only if the child has associated findings like pallor, tachypnea, altered sensorium, seizures, paralytic ileus, or oliguria. So most of the acute diarrheal episodes can be managed effectively in the absence of laboratory investigation. Laboratory investigations are not always required, only in cases of complications, which we have mentioned, that is neurological complications or respiratory complications like acidotic breathing. These are required. Otherwise, correction of hydration is the first and primary importance in managing these patients. Next. Components of management, again, as we have already discussed: rehydration, early recognition of danger signs, oral supplementation of zinc as per the WHO protocol, and ensuring adequate feeding. So breastfeeding should be continued in case of infants, whereas in cases of children more than 1 year, soft diet or enteric feeding should be continued. Next. This is the rehydration and maintaining hydration children with no dehydration chart. So WHO based ORS and home available fluids like coconut water or rice water should be advised. Yogurt drink or vegetable or chicken soup with salt also can be given. That should be non-spicy. Then commercial carbonated beverages, commercial fruit juices are not recommended. Not recommended in the sense they carry a lot of preservatives which themselves can produce electrolyte imbalance. Secondly, the hygiene status. One is not sure of the refrigeration, and they may be contaminated with several bacteria, and that can add to the existing infection. Now, counsel about the danger signs like continuing diarrhea beyond 3 days, increasing in volume, frequency of stools, repeated vomiting, and in case of blood and stools, they are advised to return to the healthcare facility immediately. So this is the age-wise number amount of ORS to be given. So 50 to 100 ml in cases of more than less than 2 years, 2 to 10 years, 100 to 200 ml, and more than 10 years ad libitum according to the thirst. Next, please. So children with some dehydration should be treated at a hospital with ORS, and they should be the hydration status should be corrected promptly. And rehydration with IV fluid should be started at a healthcare facility which is the closest to the center. Next. Feeding should not be restricted in children at this, as this aggravates the complications and increase morbidity and mortality. So the commonest misbelief in the general population is that feeding will increase the number of diarrheal episodes. So feeding, that is why most of them restrict feeding. However, this is not to be recommended. Early feeding during diarrhea not only decreases the stool volume by facilitating sodium and water reabsorption along with nutrients, but also facilitates early gut epithelial recovery, and it prevents malnutrition. So once the child status starts improving, a higher than recommended intake is given to facilitate complete catch-up growth. So this is what is important. They lag behind during the diarrheal episode. You must have seen the child's weight. It usually lags behind once the diarrheal episode occurs. However, if you continue the feeding and after the diarrheal episode is set aside, if you increase the feeds, then these children usually catch up growth, and there is less likely chance of them remaining stunted. Next, please. Zinc supplementation is recommended. The dose of 20 milligram of elemental zinc per day for children older than 6 months of age, a period of 14 days. It is helpful in decreasing the severity and duration of diarrhea and also the risk of persistent diarrhea. So for persistent vomiting, symptomatic treatment is given with ondansetron. It can be given according to the body weight, like 0.1 to 0.2 milligram per kilogram dose per dose. Next, please. So antibiotics are not routinely indicated for treatment of acute diarrhea in children. They are indicated in bacillary dysentery. That is why the importance of history taking. The point we have included, blood in stool. If that is present, then antibiotics are justified. When acute diarrhea is a manifestation of systemic infection in a malnourished, prematurely born or young infant, age-appropriate systemic antibiotic is recommended. Antimotility drugs and binding drugs are not recommended and can be harmful. And anti-secretory drugs like Resicadotril or Drotil, which we use, and probiotics are not routinely recommended. So management of acute dysentery, first line of treatment is IV ceftriaxone. In a stable child, ciprofloxacin again that has been written, but should be given to older children where there is less risk of cartilage damage. Oral azithromycin can be used for shigellosis, but then the experience is limited. For children with amoebic dysentery, tinidazole or metronidazole is the drug of choice and it can be safely given. So any young child presenting with blood in stools or persistent abdominal pain should be suspected to have intussusception and evaluated accordingly. Next, please. So principles of management of persistent diarrhea, you have to correct the dehydration, electrolytes and hypoglycemia, nutritional therapy and evaluation of infection using specific cultures. Next. So cryptosporidiosis, this we are discussing especially because there are some cases which are not responding to the conventional line of therapy and sometimes it is a bit difficult to be diagnosed. Next. The most common bacterial infection, the most common presentation is acute or subacute onset of watery diarrhea. Now, disease severity can range from asymptomatic to profuse cholera-like diarrhea, and most severe symptoms tend to occur in immunosuppressed patients. And transient diarrhea alone is typical in patients with competent immune system. That means if the patient's CD4 is good, then only transient diarrhea occurs. Whereas if CD4 count is severely suppressed, then a severe diarrhea can also precipitate. Fever is present in approximately 1/3 of patients, and malabsorption is common. Now, epithelium of biliary tract and pancreatic duct can also be infected with cryptosporidium, leading to sclerosing cholangitis and pancreatitis secondary to papillary stenosis, particularly among patients with prolonged disease and low CD4 counts. So this has to be highly suspected in patients presenting with jaundice or patients presenting with pancreatitis. And in presence of such clinical manifestations, investigations towards cryptosporidium must be carried out. Now, how is it diagnosed? It is diagnosed with a microscopic identification of oocyst. Now, as the name suggests, cryptosporidium means the spore or the oocyst is classical in that the size of the spore is cryptic. That means very small or may not be even identified. So the name suggests. And concentration methods may facilitate the diagnosis. So stool concentration. Sometimes second or third sample also has to be serially submitted in order to get the diagnosis. But careful observation and a good microbiology team can really help you in diagnosis. You may also give the clinical history along with the stool sample, saying that the patient's CD4 is less than 200 or whatever, and that will help the microbiologist to detect this cryptosporidium. And cryptosporidium enteritis can also be diagnosed from smaller sections. A single stool specimen is usually adequate, but sometimes you may have repeated samples in cases of milder disease. Prevention, you have to ask patients to follow hygienic principles as we've already discussed. Then treatment is with oral or IV rehydration, replacement of electrolyte loss, rapid ART initiation, nitazoxanide 500 milligram to 1000 milligram oral twice daily with food is very effective in treatment of this condition. Paromycin is not readily available. 500 milligram orally QID for 14 to 21 days is another therapy. Next, please. Next, please. Next. So, cystoisosporiasis. Now, this nomenclature has changed. If you go through previous textbooks, it mentions isosporiasis. The causative agent is Isospora bellae, or it has now been labeled as Cystoisospora bellae. Now, isospora means the two oocysts are identical looking, and belly means it is an infection of the intestine. So that was the nomenclature used previously. Now it is a very commonly occurring diarrhea, and in PLHI with reduced CD4 count, associated with abdominal pain, cramping, anorexia, nausea, vomiting. Diarrhea can be profuse and prolonged, particularly in immunocompromised patients in severe dehydration, electrolyte abnormalities like hypokalemia, weight loss. Infection is diagnosed by detecting Isospora oocysts in fecal specimens. And infection can also be diagnosed by detecting oocysts in duodenal aspirates in developing stages. Now, as I already said, the Isospora oocysts are very classical. In that, there's one capsule, and in that you can see two identical spores. So, or cysts. Then, cotrimazole prophylaxis has a definitive role in the prevention. Next, please. So, treatment is trimethoprim sulfamethoxazole combination oral QID for 10 days. Like, just we'll use it for pneumocystis carinii infection. Then one approach is to start with cotrimoxazole BID regimen first and then increase the dose. Or if the patient is already tolerating, then you can give QID straight away. Then IV therapy with patients who have malabsorption or severe diarrheas or nausea vomiting, then you can give IV cotrimoxazole. And for children, the dose is 5 milligram per kilogram per dose, and it is given twice daily in children and subsequently increased. Alternative are patients who are having sulfa allergy. You can give pyrimethamine 50 to 75 milligram orally daily plus leucovorin 10 to 25 milligram oral daily. Now, leucovorin is usually given to prevent folic acid deficiency. Then ciprofloxacin 500 milligram twice a day also works effectively. Next, please. So, chronic maintenance therapy, secondary prophylaxis, trimethoprim sulfamethoxazole orally 3 times a week. Now, secondary prophylaxis, we are saying because already one infection has occurred and we are trying to prevent the further recurrences. And similarly, pyrimethamine or ciprofloxacin can be used. Next, please. Now, other causes of diarrhea in PLHIV. So, Mycobacterium tuberculosis and Mycobacterium avium complex, they affect the small or large bowel. And in case of Mycobacterium avium and tuberculosis, terminal ileum is most often affected. Abdominal pain, distension, rectal bleeding also can occur. Hepatosplenomegaly, abdominal tenderness, ascites. Abdominal ultrasound may show lymph nodes or splenic microabscesses. This usually is a very big hint because splenic microabscesses are very easy to recognize, and it may be evidence of disseminated tuberculosis also. So megaloblastic anemia also is one of the manifesting finding in such cases, and one must be aware if patient has chronic diarrhea, megaloblastic anemia, and doughy abdomen. This doughy consistency of abdomen is very classical again in these patients. As soon as you palpate the abdomen, you come to know that this is a tuberculosis involvement. Cytomegalovirus disease causes ulceration of both small and large bowel. Colitis occurs in 5 to 10% of patients with AIDS and CMV end organ disease. Most common frequent clinical manifestations of weight loss, anorexia, abdominal pain, debilitating diarrhea, and malaise. In the colon, especially cecum, CMV can produce perforation and present as acute abdomen. So, as we have discussed earlier, CMV disease If you get CMV disease in one organ, please search for CMV in other organs as well. And diagnosis is usually made if the patient with diarrhea or rectal bleeding is found to have CMV retinopathy or on fundus examination. Or you can have a sigmoidoscopy or biopsy sample. Management is ganciclovir is a preferred therapy, 5 milligram per kilogram IV twice a day. It produces excellent results. One may switch to valganciclovir 900 milligram oral twice a day once the patient can absorb and tolerate. So, ganciclovir IV is a bit costlier regimen, but that is if you have to prevent further systemic recurrences or serious life-threatening issues, then this has to be initiated as soon as possible. Next, please. Parasitic infection, strongyloid cercoralis infection. The larvae disseminate widely. Autoinfection can occur and increasing the parasitic burden. May be asymptomatic or can present as acute epigastric pain, small bowel obstruction, chronic diarrhea, recurrent urticaria, larva currents. We have often seen patients presenting with diarrhea as well as cough. So dry cough, which is nocturnal, it can give you a hint towards a larva currents. Uh, sorry, pulmonary larva migrans. And if untreated, this can lead to hyperinfection syndrome in patients with HIV, causing meningitis and multi-organ failure. And treatment is ivermectin, which is highly effective, 200 microgram per kilogram orally, or as a single dose for 1 to 2 days. If ivermectin is unavailable, albendazole 400 milligram twice a day for 7 days can be used. But ivermectin has a very good rate of parasite clearance, and if suspected or found incidentally, it should always be treated. So, usually, high eosinophil count in the CBC, that also can be a pointer towards this infection. Giardia lamblia. So, metronidazole 2 gram daily for 3 days, or tinidazole 2 gram single dose. It can be given. It can in children, metronidazole 15 milligram per kilogram for 24 hours divided thrice a day, and for 5 to 10 days. So you can use tinidazole for children more than 3 years of age, maximum up to 2 grams. Next, please. Non-infectious causes of diarrhea. So lopinavir, ritonavir associated, and Kaposi sarcoma. So lopinavir associated diarrhea, it is very common, and all of you must have seen at least few cases. Some may have seen even more cases of lopinavir associated diarrhea. If other causes are excluded, loperamide can be given and switch to atazanavir ritonavir if available. And now this problem I don't think is going to occur because lopinavir is not available, or it's very available in very few centers. If also on TB treatment, atazanavir or ritonavir must be taken with rifabutin and not rifampicin. So, as you already know, rifabutin needs to be given in cases of TB and concurrent lopinavir therapy. Kaposi sarcoma, we have already discussed earlier, affects the small and large bowel, and 80% have GI system involvement. Undiagnosed Kaposi sarcoma is commonly seen at postmortem or autopsy samples of patients who die because of other diseases, and often there are no symptoms of GIT involvement. Anemia is common, and PLHIV with Kaposi GIT involvement is likely. So, non-specific complaints plus anemia, evaluate for Kaposi sarcoma. And treatment is urgent chemotherapy and effective antiretroviral therapy. So you need a medical oncologist opinion for this. Next, please. So let's discuss in brief about the anal lesions, the infective and the non-infective ones. Next, please. Next, please. Non-infective anal lesions. So perianal hematoma, thrombosed piles, perianal abscesses, and perianal fistulas. These are usually the more of surgical presentations. Perianal hematoma is usually a painful lump which is worsened when the stools are passed, and these patients are often constipated. This painful purplish lump under the skin can be visible, and this usually gets absorbed on its own. Sometimes it may get complicated by infection or bleeding. Thrombus piles, again, these are very painful swellings in the anus with bleeding, and this is a surgical emergency and needs immediate referral. So surgical intervention is desirable. And perianal abscesses, these are unlike other abscesses. These are like hot and often look as if there's some pus inside, and urgent incision and drainage is required. Perianal fistula is most oftenly presenting with anal discharge, and chronic discharges in PLHIV are likely to be because of tuberculosis. Sometimes Crohn's disease also can present with a perianal fistula in PLHIV. Next, please. Infective anal lesions in PLHIV, herpes simplex is a painful cluster of vesicles or shallow ulcers. Treatment is acyclovir 400 milligram thrice a day, just like the oral herpes, what we have seen earlier. Human papillomavirus lesion, this is very important. It presents as a wart or a condyloma acuminata with typical cauliflower appearance. Treat according to the locally available preparations. Usually podophyllin is applied and presents as an anal sore. It is a pre-malignant condition, and that is why it needs referral to the surgeon for further management. Proctitis, this presents with anal discharge, and it may be mild or severe, and painful defecation. That's a very common complaint. Syphilis can present with the primary chancre and classical painless ulcer with the raised edges, or as wart looking like HPV warts but less raised. Next, please. Thank you. So I think we have covered most of the gastrointestinal opportunistic infections. Now I hand over the proceedings to Ms. Shweta for further proceedings.
Thank you so much, ma'am, for facilitating this important session. Any questions from the participants? Any questions regarding gastrointestinal infections?
Questions can be emailed also. I will reply to them
Sure, ma'am.
later.
We'll do that. We'll do that. Any questions from the participants? You can unmute or you can put your questions in the chat box. Ma'am, I don't think there are any questions. Thank you so much for facilitating this session. Thank you to all the participants for patient listening. We'll conclude the session now. Thank you, ma'am.